Hello and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Incontinence-Associated Dermatitis. Our objectives today are discuss the function of skin, identify the 3 layers of skin, identify common skin problems related to incontinence, and discuss prevention and treatment strategies for skin breakdown due to incontinence. If you have a question about anything being discussed today, please call or email anytime during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access the materials. Continuing education credits have been approved for nursing and social workers for today's program. The Alabama Department of Public Health is an approved provider of continuing nursing education by the Alabama State Nursing Association. The association is an accredited approver of continuing nursing education by the American Nursing Credentialing Centers Commission on Accreditation. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, CE credit will only be available for 2 years from today's date, which is January the 22nd, 2014. There is no financial relationship between the planners of this program and the speakers. There is also no commercial support for this program. Alabama Department of Public Health does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. Please note the content of this program is based on policies and procedures of the Alabama Department of Public Health, Alabama and federal statutes, rules, regulations, and guidelines. Viewers not employed by the Alabama Department of Public Health should always check to clarify whether the content is accurate according to the statutes, regulations, and policies of your respective jurisdiction or agency. I am Shirley Offit, Nurse Consultant of the Bureau of Home and Community Service, and with us to present our program is Jackie Giddens, also a Nurse Consultant with the Alabama Department of Public Health Bureau of Home and Community Services. Boy, I stumbled on that one, Jackie. That was a lot of reading. Welcome.
Thank you, Shirley.
And is incontinence-associated dermatitis just an ongoing problem we see all the time?
Well, it is, and it's a newer, I guess, if you will, a fancier word for really diaper rash is kind of what we used to call it. But we have a lot more to talk about in relation to the skin, the moisture, and then how incontinence affects that. And it is a huge problem. Those of you who've been in home care for a while and even in the hospitals and nursing homes, you know there's a push to get away from diapers, to get away from catheters. So dealing with incontinence appropriately is certainly a huge, huge issue. So we'll get started.
All right.
All right. The skin is an organ. It is the largest organ. It's the heaviest organ. It makes up about 15% of the weight of someone. So this example here is of an average person, say of 150 pounds. Their skin's going to weigh about 12 pounds and can cover 18 square feet.
Wow.
1 inch of the skin, it's very dense with a lot of things going on there, a lot of structures. This shows you, this particular slide just kind of outlines for you all the things that would be in a square inch of skin. 100 sebaceous glands, 65 hairs. I'm not sure if I have that many per square inch, but hopefully I'd like to have that many at least. 78 yards of nerves, 650 sweat glands, and 19 yards of blood vessels. That almost seems impossible in a square inch, but that is how remarkable this organ is. I'm going to talk a little bit about, there's some other little details there for us. The nerve endings, the sensory cells, bacteria, which is natural on the skin, It's just when it gets the wrong bacteria or gets out of balance, then we have issues. And then you see how many cells are there. So there's a lot of stuff going on the surface of the skin. The function of the skin, we're going to talk about those. One of the most important, and the first thing we think of, is to protect the rest of the body and be the first step in the immune response. The structure of the skin, as you can see from just all those things that are in the skin as well as the functions, it's real complex, and it's divided into 3 layers. We're going to go into great detail here in a few minutes of the epidermis, which is the outer layer, the dermis, which is the deeper layer, and then the hypodermis, which has very specific functions, and then they call these two sometimes the skin appendages, so what's just below the surface of the skin. Again, protection and response, immune response is kind of the first things that we think about with the skin. Hydration. Obviously, the skin protects the rest of the body from dehydration. All of us can think about, when you had a little skinned knee, it would be superficial, but that little fluid would kind of bubble up there and maybe just a little bit of blood. And so our skin, of course, our bodies are made up of 70–80% of water, and the skin is the first major organ that helps to maintain hydration and keep the tissues that are underneath moisture, keep their moisture levels appropriate. And without that, the most elementary of functions of the cells of the body could not function. Body temperature regulation, that's another huge function of the skin. It controls our body temperature regulation with the expanding or contracting of the vessels. The blood vessels will dilate and release heat from the body, and they contract, and then they will restrict the heat loss. Increased perspiration, as we know here in the South, in the summer, will cool the body, and then decrease will keep us warmer in the winter. We're experiencing very cold weather today on this January 22nd of 2014. So I've had a couple of folks to say something about drinking some alcohol to make them warm, and we won't go into that lecture today, but actually it will not make you warm, and it will actually make you colder. So just keep that in mind. You might want to be by the warm fire if you're going to be having a little nip of anything during the cold weather. The skin, another function is sensation, and of course this couple of examples here with the person with Braille, how important that would be for someone who's blind, because they can actually read, of course, with their fingers. And so the skin over various parts of the body, there's more or less sensation, more or less nerve endings, and it reacts to the heat and the cold, as we said, sharp pain and pressure. So it will provide a lot of protection from injury, just like with our fingertips. That skin's tougher, and our feet, because we're utilizing that a lot, those surfaces a lot, whereas, say, in the back of your neck or under your arms, that's going to be more tender place. Another very huge function of the skin is related to the storage and metabolic functions of the skin. It stores water, lipids, fats, waxes, cholesterol, vitamin A, D, E, and K. The functions of the skin is also to interact with the UV light to help with the synthesis of vitamin B and vitamin D. So those are extremely important. We're finding now that we're reading in the literature that a lot of people, even in the South, are vitamin D deficient, male and female. And then vitamin D, as you know, relates to, actually they have found a connection with that and depression and some other things. So there's it's just a very wide range of issues that the skin, related to their function of storage and metabolic function, can relate to other issues. It's also the place where there's several kinds of building blocks, if you will, in mortar, and that would be the protein and the enzymes. The collagen is the protein. We're going to go into a little depth about these and see some actual little photographs that'll help us, but just think in terms right now of just any structure with the brick and mortar or the pieces, the blocks that these things are showing. But the collagen is actually that structural grid that holds things together. Most of us ladies have heard a little something about collagen because we're concerned about our skin, our face not sagging and this sort of thing. So that and the elastin, which is also a protein, and the GAGs are and the proteoglycans. The GAGs are the glycoaminoglycans. These things all work together. That's a polymer. These things all work together to hold the structure and to hold the moisture within the skin. I will tell you that those glycoaminoglycans and the proteoglycans are the very special biological polymers, or glue, if you will, which play a key role in holding the moisture into the skin. And in essence, they are extremely effective natural moisturizers. So they're a lot more effective than the things that we put on our skin, because these are in the skin naturally. And they have to be hydrated, and that keeps the skin plump and fresh, and it provides the mechanical support for the structures of the skin cells.
Now, Jackie, are they kept hydrated from the fluids that we drink, or what?
Yeah, it's part of the structures of the skin. So yes, if you're not taking in enough fluid, then that could be, you would have dry skin. If the functionality of the body, if there's some issues with the function of the skin, ergo pressure, incontinence, something causing damage to the skin, a lot of sun damage and that sort of thing, then those things are going to be reduced, or their effectiveness will be reduced. And then also, as well as the nutritional status of the person, which is extremely important, going back to those vitamin A's, D, E, K, the things that affect the skin directly. That's a good question. Another major function of the skin is not only is it protecting us from the outside, it actually absorbs oxygen, carbon dioxide, nitrogen even in small amounts. And now we've got a lot of medications that we're using topically through the skin. The skin's very selectively soluble to fat-soluble substances like vitamin A, D, E, and K, and then the hormones like estrogen. So the substance can enter the bloodstream pretty quickly through the capillaries in the skin, and we saw earlier how many capillaries there are, and just the enormous amount of blood interaction there could be at the skin, at the surface of the skin. These patches, we've got the hormone patches. We have, I think, for both male and female hormones. I know that another new medication out there you've probably seen on television, because incontinence is quite a hot topic. Not only do you see the diapers and the lady going to the store with the Depends, and the thinner type ones so that they don't show under your clothes, but also there is a couple of drugs that they have actually made where you can use a patch for incontinence. So, so the skin is extremely important. Of course, there's nitroglycerin and the nicotine for those who want to quit smoking. So not only can it absorb medications, but obviously it can absorb chemicals in the environment as well. Excretion, well, our skin absorbs, but it also is part of the excretory system, along with the GI, the urinary, and the respiratory, but also the skin is actually part of that. So it helps us take out part of the garbage, as you see here as an example. It excretes excess water, urea, and other minerals. And of course, we've all heard of the term pheromones, and that studies have shown that actually the skin can excrete these pheromones, which have an impact on hormonal balances of other folks of opposite gender. So if you've not noticed that, you might do a little more research on that. It's kind of interesting and fun to talk about. So a lot of stuff's going on there with the skin. In this very short, very small linear organ, it's not a deep organ, even in the deeper parts. But there's a lot of stuff going on, and it's extremely important. So let's look at the layers of the skin in a little more depth. The epidermis, which is the upper layer, the dermis, and then the subcutaneous tissue, that's another term for it. So we've got a lot of slides to look at here, a lot of illustrations and some photographs for you we'll get to in a few minutes. All right, so here's a very basic illustration of the epidermis, which is that very thin layers, almost like little pancakes stacked on each other. Very thin ones are crepes, perhaps more than a pancake. And then the dermis is the thicker layer, which is underneath, and that's where you see a lot of the structures. Then in this particular illustration, it shows what's below the dermis is the hypodermis, is the term. You could call it subcu, fatty tissue, but that's where you see the larger blood vessels. But again, remember those big numbers we saw? Well, then here's those structures just illustrated in there, the hair and the sebaceous glands and the circulatory system there. So there are actually 5 layers to the epidermis. I'm not sure if you've heard this or remember this from any of your anatomy classes, but it sounds kind of odd. Again, we're talking about all these things going on in a square inch, and now we're talking about 5 layers to something that can be extremely, extremely thin, like millimeters thick. But these are the 5 layers. There are some areas where you may not have one of those layers, but for the most part, this is typical of all the skin. From the top to the bottom, we've got the stratum cornea, the stratum lucidum, the stratum granulosum, the stratum spinosum, and then the basal. And all these things fit together to make that epidermis. Just the epidermis now, not the dermis. From top to bottom, as I've named them, the epithelial tissue covers the internal and external surfaces of the body, and it forms those glandular organs. The squamous cells are the thin, flat, fish scale look. And then the stratified means having more than one layer. And then in short terms, the epidermis is composed of all these layers. And what happens is that at the basal level, the cells are fatter, and then they sort of move up through the process of as they are approaching the surface of the skin, where they become thinner and thinner, and then eventually are flaked off. All right, so the stratum cornea, that's the outside layer. It provides the first step in protection. It sloughs off in about every 2 weeks, and they call it also the crusty or the horny layer. And we'll see some photographs of that in a little bit. Some other things to know: this might be the total thickness of the epidermis might be 0.5 to 1 millimeter. So again, that's very, very thin. This outside corneum layer is the skin cells that are at the end of their life cycle. So they are the ones that provide a little bit harder, crusty layer, if you will, to try to keep the infectious organisms at bay. And you can think of this kind of like mulch over a flower bed, if you want to. And that the epidermis is holding in that moisture, and it's protecting the raw nerves from too much stimulation. It is made up of 3 types of cells, and that is your keratinocytes, your melanocytes, and the Langerhans cells. So the keratinocytes, as you may recognized by the name, are the cells that make the protein, keratin. And then they are the predominant cells of the epidermis. Then the lower portion of the dermis, as it matures and it divides real rapidly, those keratinocytes start losing water and they start thinning out. So the top layer of the skin, this corneum, is made mostly of those dead keratinocytes, because they're hard and they do have some lipids in there, but it just kind of forms a crust. We'll see again this little slide of the actual thing in a few minutes. And that does, like we said earlier, it sloughs off about every 2 weeks, 3 to 5 weeks for sure. And of course the melanocytes, which bring the color and the pigment to the skin, are important for that. And then the Langerhans cells, which are the first defense in our immune system. That's the stuff that actually helps to prevent the bacteria to come in. So here's that epidermis, the very top layer. This is like looking down on it, and you can see that it's like plaques or stones that are almost stacked up on top of each other in a pattern.
Now, Jackie, my skin doesn't look like that when I look at it.
Well, I don't know how many times this is magnified, but a lot. It's tough. You can see it's overlapping. These are dead skin cells. They're not alive anymore. And hey, did you know that's where dust comes from in our houses?
Yes. Boy, I've got a lot of dead skin cells in my house.
So that's where it comes from. And then there are those folks who will happily show you how much is in your mattress if you want to look at their vacuum cleaner apparatuses.
That's okay.
And
That's okay.
yeah, we don't want to go there. Just get a mattress cover if you're worried about it. All right, so here's another illustration. Again, it's giving us a little better look at all those layers of the epidermal layer, the corneum, lucidium, granulosum, spinosum, and the basal. And then you see there it says a basement membrane. So that's like the bottom of the bottom there, okay? Before you get to the dermis. Now, all of this is before you get to the dermis. So you can see almost those little finger-like structures that are sticking up into the stratum sections. And you can see that those little cells look they look fat and plump, really nice and blue down there at the lower level. And then as they start flattening out, they've changed their color there so we can kind of distinguish it. And then as it goes up, those layers just get thinner and thinner. And here's another illustration that kind of is a slice so that it kind of gives us again another visualization of how at the bottom in the basal layer you've got that nice plump cell, and as those cells migrate upwards, then they are getting thinner and thinner. The stratum lucidium, which you can tell from the name, is the clear layer, and it has a lot of refractive qualities, so the light gets refracted from it. And again, those have been flattened out and they're real close, and you really can't tell where the cell boundaries are. So that's the one just below the very outer edge, outer layer of the skin. And then the next layer, the granular layer, or the stratum granulosum, is what they call the prickly layer, and that again is where the keratinocytes, they start doing their thing there, and that's when that protein and those filaments form. And again, that along with the other fluids in the cell is what helps to protect us from the things that are going to come against our skin and keeps that barrier out. So you could think of them as that front line. And then the prickly, and then the basal layer. That's another names for it. All right, we'll move on to the layers of the dermis. All right, so again, the epidermis had a lot of stuff in there that, you know, you really don't think about how much is in that very, very thin layer. So here's a thicker layer. So here's where we're going to see more structures within the dermis. So you've got a lot of collagen fibers there. You've got that thicker layer with thicker collagen that run parallel to the surface of the skin. There's blood vessels, which is very important here, where it transports the vitamin C to the back into the rest of the body, because that's, the vitamin D back into the body, because that's where the vitamin D is synthesized. You've got the lymph system, and of course the lymph system is extremely important. That's what helps to bathe the tissues of the skin, and also that is a major the major fluid that helps to destroy any of the infection or anything, any organisms that are trying to invade and enter into the body through the skin. The hair follicles are there, the sweat glands. There's actually a couple of types of sweat glands that are in there. One produces kind of a milky sweat, and the other one is a true sweat gland. And they're just, it's just amazing, all the sections that are in there. And then the sebaceous glands and oil glands, or oil glands, you could call that. In one of the examples I read, it says you can think of, we talked about the epidermis being the mulch. You can think of the dermis as being the topsoil. So it's very rich, a lot of things going on there, and it has to stay moist because that mulch, that top layer of epidermis, is going to protect it. Here we see kind of where remember those little finger things that looked like they were going up into the epidermis? In that illustration, this would be a microscopic view of that. Excuse me.
Looks like little underwater creatures.
Yeah, it does, almost like a coral.
Yeah.
Or something. And then here's our collagen fibers in the lower layer of the dermis. Again, that's a structural. That makes me think of some type of metal rods and stuff like they use for reinforcing concrete or something. And that's really kind of what it is, that it produces that structure.
Now, is that the same thing as this collagen cream I'm trying to put on my face to stay younger?
Yeah, the problem is it just doesn't get deep enough most of the time. I'm going to go back here just for a minute. You can see, again, those finger-like things, but not only that, it creates unique patterns, and it increases the gripping ability of our hands and our feet. So, these things are essential in order for us to function properly. And then, like I said, the collagen. Each one of these layers, you can just go deeper and deeper into the science, into the anatomy and physiology of what's going on in each of these, and I really enjoy that kind of thing. So I won't get too bogged down here, but I just think it's important for us to really get the impact of what all is going on in that skin. The dermis, again, is held together by this type of protein, which is the collagen. It's made by fibroblasts. You may have heard of fibroblast cells, and that's what gives the skin its strength and its resilience. Now, that's very important to us who worry about our little wrinkles coming, because not only does it need to be, your skin need to be strong, but it's got to have that ability to bounce back or be resilient. And of course, we know that changes with age. Again, the collagen is tough. It's insoluble protein. It's throughout our body and in all the connective tissue. It holds muscles and organs in place. But in the skin, it supports the dermis. That's the foundation, if you will, for the epidermis. And it helps with the durability of the skin. Elastin is another protein. And of course, obviously by the name, that is the one that is the major responsibility, is to help with the skin being flexible. So Stretch Armstrong, he had lots of elastin. That would be a way to think of that in terms of remembering it. Auricles arise and develop in the dermis. So if all these things that I put on my face, or we all do, very few things do get deep enough into the dermis to make a whole lot of difference. One of the biggest things you can do is, if you're a smoker, don't, because that does cause wrinkles. Again, you can think in terms now of what we've talked about with the chemicals and the smoke and just the drying out of the skin if for someone who smokes. And I think most of us now, if you look at someone who smoked for a number of years, their skin may not look as good as someone else in their family or someone else their age. A lot of what has to do with those things, though, is our just our genes. You know, if your mom didn't wrinkle before, you know, and not being in the sun very much and protecting us from the sun. So this kind of, like I said, we said earlier about all the things that are in the dermis. This is for all the structures of the skin and the specialized cells that are in the skin. Again, here's another different illustration that just kind of shows a little bit more structures that are going on there, and then those finger-like aspects of the dermis that are going up into the epidermis. You can see that that's what, when someone has a shear injury on their, say, in their lower sacrum, part of the reason where you and I, most of us, could slide up in the bed and that skin not tear. Well, with someone who's older, the skin is thinner, some of those functionalities are not going as well, then those little fingers are not going up into the epidermis like it needs to, so you get a better chance to have that shearing effect, which can be at more surface level, or it can actually be from the bone and then the subcutaneous tissue. And the subcutaneous level, which I don't know how well you can see it where you are, but that lower level there has little bead-looking things. I had some really good pearl couscous this week, and that's what it looked like, those little round yellow-looking structures. But that's the subcutaneous tissue. It's a shock absorber. It's a heat insulator. It has all these other structures in there as well, depending on where it is in the body. Of course, they're all going to have the blood vessels and the lymphatic system and the nerves. And there's even muscles attached to our hair follicles. So maybe I should be working those out. I don't know. Here's another illustration of the subcutaneous layer. It shows those little, almost bead-like fat cells. All right, so now we're going to turn to incontinence. And we're not going to get into a lot of detail about incontinence. That would be a whole nother lengthy lecture. But we'll just turn our thoughts towards incontinence, and then we'll put these things together. Incontinence, of course, is the involuntary leakage of urine or stool. Urinary, of course, is loss of bladder control. Fecal is loss of bowel control. Let's see, this was way back in '96. There was 13 million people that suffered from urinary incontinence. Obviously, that is just hugely increased. There are more women with incontinence than there are men, but men do have incontinence, both the bladder and bowel. Now again, we've got a lot of things on the market related to bladder incontinence for men and women. Things are being discussed a little bit more for the advertisements. But fecal incontinence is extremely hard to determine exactly how many people it affects, because it's something that nobody really wants to talk about or address. But there are lots and lots of things. If you have patients with urinary or fecal incontinence, there are, it doesn't just naturally come with age. There are a lot of things that in the aging process may affect either one of these. It could be structural, it could be cognitive, the reason that they just forget to go to the bathroom. It could be functional, where if they could get to the bathroom or get to a bedside toilet soon enough, they know they need to go, but they just can't get there. So it's very, very important that we begin to look a little closer at what is causing the incontinence for our patients, because we may be able to do some very simple things and make a huge, huge impact in their quality of life and the cost for them and the care for their family. It may be something as simple as getting a bedside commode, or it may be something as simple as getting them assessed by a doctor and getting the appropriate medication. But just because somebody has urinary incontinence does not mean they need to be on medication. That might not be the issue.
And you know, Jackie, I can see that incontinence, both bowel and bladder, can be a real bad self-esteem thing for a patient.
Absolutely, absolutely. And again, you know, the urinary is difficult. The fecal is almost impossible for someone to be able to leave the home and you know, function in any age. And these things are much more common than you realize. Most women who've had vaginal deliveries will have some urinary and bladder issues at some point in life. You can just kind of bet on it if you've had the vaginal delivery. Fecal incontinence can go along with that too, you know, with episiotomies and various repairs, and they may be okay for a while. Obviously lifting and things. I mean, there's just a lot of reasons that that you can have these issues, but there's also a lot of, if you will assess that patient fully, find somebody who could help you assess them. I am certified in continence as well, so any of you who want to take the extra step there that are with the Alabama Department of Public Health, I can give you some tools to help you to assess the patient if you can't get them to a specialist, and just try some things. All right, so what causes it? We've already been alluding to some of these things. Constipation will cause both fecal and urinary incontinence. Person's diet, they could have, maybe they just need to change their diet a little bit because they've got diverticulitis and they don't need to be eating seeds or whatever. GI disease, of course, hormone imbalance. As we go through menopause, the estrogen levels go down, and estrogen is extremely important in maintaining our continence because it definitely affects the musculature of the pelvis in women. Anything that would cause you to lose your muscle function in the pelvis obviously would affect both bladder and bowel incontinence. The loss of mobility, as we mentioned earlier as well.
Jackie, before we go on, you said that constipation can cause urinary incontinence.
That's correct.
Actually, elaborate on that.
Actually, it's actually one of the most common reasons for urinary incontinence. It has to do with the pressure that's being applied from the bowel to the urinary tract, and so we don't think about that. One of the physicians I heard, and I'm sorry I can't tell you his name right now, I could look it up, but he's out of Atlanta, and that I heard one of our lectures, and he was the first person that I heard that really has a campaign for looking at the entire pelvis as one unit rather than dissecting it to the reproductive, the GI, and the GU systems, and looking at it because not only is the knee bone connected to the leg bone, everything in the pelvis, obviously because of proximity, because of blood supply, because of nerves, because of muscles, that's a very close area. So whether you're male or female, one thing will affect the other.
So our patients that have problems with constipation, we really need to look, is that the cause of their urinary incontinence?
Absolutely. So again, that could be something really simple that could be addressed and actually improve or eliminate their issues with incontinence. Stress incontinence, you know, when somebody coughs and they have a little, and they wet themselves just a little, you know, there's all kinds of things that can be done to address that. And that's really, really common too. Medications can affect constipation, so therefore, you know, so it's
like a domino effect here,
very
one
much
thing
so.
for the other.
Very much so. Some other things I believe we've got on here. Yeah, mental changes, of course, as we said, they could cognitively not remember to go to the bathroom or remember where it was or that sort of thing. Prostate disease, very high, of course, with men as they get older, that increases. It's important to find out when you're assessing your male patients, have they had their prostate checked? It's extremely important. If it's caught early, then there's usually, you know, a much better outcome, as you know. And prostate surgery, there are some nerve-sparing techniques depending on the severity of the disease. But quite often, a person who has prostate surgery can end up with at the very least temporary incontinence. It could go more. I know I used to have a lot of male patients who'd go in the home and nothing in there indicated that they were incontinent, but you'd have that strong smell of urine. So we might need to dig a little deeper and help those male patients as well get some treatment early on. Spinal cord injury, of course, and then urinary tract infection. In fact, I'll just mention with spinal cord injury, no, it is actually a life and death situation if with a spinal cord injury you have a bladder that is not emptied. That can actually be a very serious situation. So, incontinence is a total lecture for another day. So now we're going to kind of relate the incontinence back to the skin. So why does incontinence harm the skin? Well, I don't know about too much of a good thing if I could be looking at some nice little waves, but that would be fun right now. But too much water, and it can be too much of a good thing. So moisture. Moisture of any kind, not just with incontinence, but with perspiration and skin folds and everything. So just kind of keep that in mind. You can apply this to those kinds of things as well. Even though I said it's essential, but both stool and urine can have the moisture that will really cause problems. So when we talk about the skin surface and incontinence or even moisture and maintaining the skin integrity, we have to look at the pH, which is very important. pH of the skin is slightly acidic. It's actually around 5.5. And hold on to your seats, because we're going to have some blasphemous words here in a few minutes about soap. But it needs to stay a little bit acidic because that helps fight off the bacteria. Urine is often alkaline, so right there we got a problem. So that means the pH is high. Ammonia, for example, is alkaline. And usually you have that strong smell of urine, you know, you have that strong ammonia smell often. And when that happens, and the urine could be like 10 or 11 in a pH when you have that odor. And then you've got individual person's basic base and acid-base status, where their urine usually stays. It can be anywhere from normally for them anywhere from 4, 4.5 to 8. So obviously you can see we can get off there pretty easily, depending on the diet and some other things. You know, you could have a diet that's really high with citrus and legumes, and that's going to keep the urine really alkaline. And high in meat and cranberry juice is going to keep it more acidic. So sometimes we can actually, the diet can be an issue if you can't control the incontinence the way that you need to. Stool, usually it's about 7 to 7.5. Thinner stool, of course, can have a lot of enzymes as well as intestinal bacteria, along with a pH that is not going to be optimal for the skin. So the bottom line is exposure to the skin to stool and urine is going to cause some skin damage. It's just a matter of when and how much. And of course it does all these things, and it increases that issue with friction that we were talking about earlier too, because not only mechanically, but where you've got someone who's incontinent and they're on the bed and then their skin kind of sticks, but you've also got the physiologic stuff going on where the breakdown of the alkaline pH is there, so, and increases the growth factors there for the infections and yeast. And incontinence-associated dermatitis is a term that is relatively new in the last 10 years. And so it just kind of pulls together and describes that syndrome that we've seen. It's this excoriation of the skin and skin breakdown. Of course, pressure ulcers are increased. The chances of those are increased when you have incontinence. All right, we're going to get into some slides here with some photographs, and I'm going to cover this one, and then if you like, we can just take a break.
Sure, that'd be great.
Okay. And we'll see some more. So here's just an example. This was not caused by this folliculitis is not caused by the incontinence, but incontinence could contribute to this because the skin pH would be altered. The skin would not be doing what it needs to do to protect one from the staph infection. So you've got the follicle, the hair follicles that have become infected with the Staphylococcus bacteria.
So is this like if you're not incontinent but there's just a lot of moisture?
That can cause it as well. Again, the incontinence of feces or bowel is going to be worse than just moisture because it is going to have that altered pH and cause some problems. The staph is normal on our skin. It's on everybody's skin. The issue is where you've got, in most of you don't have, everybody doesn't go around with this type of an infection. What happens is there's some kind of compromise, which could be many things. It could be some other system that is not keeping up the immune system for whatever reason. But one of the biggest reasons here, it can be that the skin has been damaged already or broken, but damaged in this case we're talking about by urine or feces, so then the bacteria can get into those hair follicles and then produce this type of infection.
Okay, so at this time we'll take about a 10-minute break, and we'll see you about a few minutes before 3 o'clock.
Thank you.
Welcome back to the second portion of our program, Incontinence-Associated Dermatitis. Remember, if you have any questions, the 1-800 number is listed at the bottom of the screen, or you can email any questions you have for Jackie. And Jackie, before you get started back, we were talking during the break time, and I always think about my vital organs, because I have coronary artery disease, and I think of how my heart and how I've got to take care of everything with this and of my lungs and whatever. And I think you just brought back the realization that my skin is just as important and as a vital organ as my heart and my lungs are.
Yes, thank you. Yeah. Well, maybe not quite as vital as your heart at any given time, but yes, you are absolutely right, because that is our first defense against any kind of bacteria and organisms that would harm us. We still have the picture up from the last one there. Shirley also made a comment, this looks like buttocks, and it looks like it's probably somebody young. And I said, yeah, it probably is. And they may or may not have had any incontinence issues. One of the reasons that I'm going to include this in the next few slides is to just so we can kind of differentiate between what is caused by incontinence, as well as to see some skin problems that can occur when our skin is not as healthy as it should be, one of those things being incontinence. So we'll just hurry right on through. Here's another type of skin lesion that you might see, and this can be caused by staph as well. This is like a furuncle, is what they call it, furunculosis, boils and that type of thing. Impetigo, that's one. Strep, which I didn't have slides for, but strep can cause cellulitis, impetigo as well, necrotizing fasciata, and lots of other things. So just kind of throw those out for you. Of course, one of the most common skin infections is going to be yeast or fungal. It can happen anywhere in the skin folds. It may create its own moisture. It can be fiery red. It can be white coated, satellite lesions, red spots scattered at the edges, kind of the hallmark description. And here's, I'm going to show you a few slides of this. This is other terms, of course, is candida, jock itch, toenail fungus, dandruff, athlete's foot, ringworm. Ringworm is very distinctive. Is not a worm, but it is a fungus, and it usually comes in a circular pattern. Armpits under the pedicula, of course, like this, with someone who's heavy. It's very difficult to treat. We have some patients out there that are patients that have some very, very serious yeast issues, so they may need to be treated with something systemic for a time, some diflucan or something else. As well as topical. We'll talk about that. Of course, this is a classic in the peri area, and you can see the little satellite, the redness, and then the satellite areas. That kind of gives you a clue that that's probably yeast. So, what do we do to manage the skin infection? Well, of course, we want to keep skin clean and dry, especially in those folds. Maximize the air that gets to the area. Use those antifungal creams and powders. Excuse me, or antibiotics, depending on if it's a fungal problem or a bacterial problem. In the same thing, you would be using oral antifungals or oral antibiotics, depending on what the organism is. I'll say here, too, that it's extremely important with something that goes on for quite a while. You may have to encourage the physician to do a skin biopsy. If it doesn't look like something that you recognize easily, then it might not be. We have some patients out in our population, I know, that have had some unusual pyoderma granulosum. We've got a lady now, they're looking at trying to figure out why the lesions have opened up the way they have. It could be reflective of an autoimmune disease. Rather than actually one of these other things that we've talked about. So it's really important that we do assess the skin appropriately.
Jackie, we've still got a lot of our older female patients that still wear those silk undergarments.
Yes. And white cotton is always best for your socks for those diabetics, and certainly for the undergarments for our patients, male or female. Bras without that aren't restrictive. They may be wearing the same size bra they wore forever, and they're not the same size, or they're laying around more often than they did, and maybe they need something without the wire in it, or something that's cotton. So that's a good point. That's something that can really, really help. We'll move on to the definition of incontinence-associated dermatitis. And Michael Gray, if you read anything about incontinence and dermatitis, Michael Gray's name will come up, and he's I've heard him speak several times, so I wanted to definitely give him credit for coining this definition for us. It is skin inflammation manifested as redness with or without blistering, erosion, or skin loss of the barrier function that occurs as consequence of chronic or repeated exposure to the skin to urine or fecal matter. Wow. So this is a really accepted and very comprehensive definition of what incontinence-associated dermatitis is. And you can actually have this occur not only in the peri area, but if you have a stoma, an ostomy, where you have some leakage around it, then it's the same thing. It still is incontinence-associated dermatitis related to the incontinence of the stoma, of the leakage perhaps. And then you can turn it into yeast and other things like that. Where it is located is usually, of course, it's going to be in contact with the urine and the feces. It may initially be red and weepy, and then later it gets dark, purple, white, even peeling like a sunburn, and we saw that in some of those examples. You don't, if it's just incontinence-associated dermatitis and you're not having a fungal infection or a bacterial infection, you're not going to see those satellite lesions. It won't necessarily be over a bony prominence like a pressure ulcer. We'll talk about that a little bit. You should have burning, itching, tingling. It should be it's probably going to be painful. Here's some examples, very mild. Yeah, there's some pressure, but if you notice the reddened area is really, really close there, and it's closer to the buttocks. So this is probably more due to the urine rather than the pressure. So what are we going to do to treat it? Again, some of the management. Of course, we want to treat the cause of incontinence, which I alluded to earlier. We want to prevent the skin breakdown, so we want to look at it, we want to clean it correctly, and we want to protect that patient that's at risk. And then, of course, treat any breakdown immediately. Pressure ulcers, just to talk about them and the differences. They're going to be over a bony prominence 99% of the time, usually around the coccyx. They're going to have that shape, the oval or round. Sacrum, ischium, they can have that butterfly look. If they're in the center, in the sacral area, they'll have more of a well-defined edge rather than those little satellite lesions. And of course, here's where our pressure ulcers can occur, most likely anywhere that there's a bony prominence and there is time and pressure. So this would be an example of stage 1 and stage 2 pressure ulcers here. I do notice that we have a lot of folks that have a lot of our wounds labeled as stage 2, in which they are, in fact, maybe 3 or 4s, but in the pressure ulcers. So if you have any issues or questions about that, we have plenty of resources that we can refer you to on the web, on our website, those of you who work with us, with the Alabama Department of Public Health. But if you'll notice on these two, they're definitely on the bony prominence. They're very limited to that area. The wound in the top, on the top cheek there, would be a stage 2 because it's actually open, whereas the one on the bottom is not quite all the way through yet. These are still considered partial thickness, and I hope now, once we did all that review of the anatomy, you can think in terms of partial thickness is going to be in the epidermis. Okay? Once the dermis gets exposed, then we're talking about a full thickness wound when we're describing things other than pressure ulcers. With a pressure ulcer, a full thickness wound would be the stage 3 and stage 4. Of course, just the basics of pressure ulcer management. Get the pressure off, keep the wound clean, moisture, protect the edges, don't massage. I will back up, I didn't add here, but of course one of the key components with pressure ulcer management is always nutrition, but in the context of this lecture, that moisture too, making sure that the wound bed stays moist, but the skin around it does not. You want to protect that peri-wound area from any any moisture. All right, so what would you say this is? We're going to
Painful.
Yes, very painful. Looks like they have a rectal tube as well as a catheter and a very scalded bottom would be the way I think my grandmother might have described it. In which it is. It's burnt. It looks like a burn because the as we talked about, the pH of the urine and the feces, particularly if they're having diarrhea, is going to definitely cause damage because it's not going to be compatible with the pH of the skin. So this is incontinence-associated dermatitis. This is not a pressure ulcer. And that's going to be important as you do your assessments for the OASIS. And what would you say this is? It's probably yeast. You see the little spots? Yeah. Of course, the area in the skin fold, that's giving us a clue. It's not on the bony prominence. The person may or may not be incontinent, but this looks like it's a yeast fungal type infection. And then what would you think these are?
Oh, that looks like a pressure.
That's a pressure ulcer. And these are stage 3s.
Ooh.
They don't look deep. They don't have to be linear deep, you know, with depth in measurement, but they're all through the dermis, the epidermis and into the dermis. So that makes it at least a stage 3. And obviously this person is older. Their cheeks are not as plump as those last ones. And you can see the sagging of the tissue. So when you get that sagging of the tissue, you know you've got thinning of the epidermis and thinning of the dermis. So this could have been caused from some shear injury. And that's why it's so deep. What would we say this is? Another very painful example of a scalded bottom, which incontinence is what we would think. Again, you're going to do a history on your patient. You're going to know a whole lot more about them than a picture. And I've said many times that, yes, a picture is worth 1,000 words, but to describe a patient's wound, you're going to need at least 1,001. We're going to need to know more about what's going on with the patient. But for our example, this is definitely that. Okay, what do we got here? Looks like we got a lot of things going on. Looks like on that hip that's turned up down on the trochanter that we've got a scar, maybe still some open area where we've got, which would have been probably a stage 4 at some point. It definitely is stage 3 when it was staged as a pressure ulcer because this person is a person of color. We see that there's not any, so we know that this thing has gone at least into the dermis. Okay, so we know it's a full thickness wound. Then those other wounds that are there, obviously the patient's probably the darker colored areas. This could be several things. It could be many things. It could be just a scar kind of tissue. It could mean that we've got any breakdown. We've got some open areas. So here I think what we've got is pressure plus some incontinence-associated dermatitis. Definitely moisture is playing a factor in these wounds.
And does that look like a blue chucks or something they
It
used
does.
to call it? Do
I'm
they
not
still
sure.
use those?
Well, we definitely discourage the use of the chucks in the bed as well as a diaper. If you're going to use a diaper, then we want you to leave it open and rather than closing it because that does increase the chance of somebody, when they're bedbound, of them getting that moisture-related damage, skin damage. It sounds kind of like the wrong thing to do, but protecting the mattress is not what we want to worry about anymore. We want to worry about protecting the patient's skin, and how can we do that? We certainly don't want to layer and layer and layer. You don't want anything, because of cost, they may be getting the thin blue pads, and then it's mostly just plastic under there, and so you're going to have more moisture because they're going to sweat, and it's going to hold it. So, it really needs to be a higher-end product if you're going to use like a diaper or something that wicks it away. And I know this is difficult, but what I'm here to help you to understand is the importance and why it has to be that way, and hopefully you can share that with your families and your patients. Now, what is this? I think we got a little bit of
Well,
both going
yeah.
on here. On the upper cheek, obviously, there's a lot of redness on both of them. So we know that moisture, probably urine, definitely played a part in this because, again, another scalded bottom. And then we've got some open areas. So that definitely looks like there's some pressure involved, probably some shear injury because you see that darker part means it's deeper. And we really can't stage that. We know it's at least a full thickness wound, so it has to be a stage 3 or 4. But since we can't see the deepest part of that wound, this is unstageable. So you've got a combination of the incontinence-associated dermatitis along with pressure ulcer. And then here is a patient. Some of these slides you may have seen before in some of my other lectures. Some of them are new, but this is a scarring area. You can see, again, we know that has been, because the person is of color, so we know that that went all the way into the dermis area. So, but it looks like it's not pressure that caused all this. It's actually from incontinence.
Now, when this skin heals back over, it is more apt to break back again because
correct.
you don't have that fullness all back.
That's correct.
Like it was before.
Anytime we have breakdown, particularly in a pressure ulcer, but you're into a full thickness wound, so anytime that happens, your tensile strength, we remember the collagen and all those things, you will never get a full 100% strength that you had before. So whatever the strength of the tissue was, it'll only, at very best circumstances, age, health, nutrition, no more pressure, whatever, it'll only get back to 75 to 80% strength back. So it'll always be a little less. If you get the second wound in that same area, then you're never going to get back to that 80% that you had before. That's why it's extremely important. Again, the whole lecture on pressure ulcers is another subject, but these all do very much tie together. But it's extremely important that we prevent the pressure ulcer from ever occurring, because once it starts, you're never going to get back what you had. And then usually those of our patients who get a pressure ulcer are going to have a lot of other comorbidities going on. And I think I shared a little something with you earlier that you had said something about mentioning that you may have heard me say before. It wasn't me that coined this, but in one of our lectures, we were reminded that Superman was actually, was what his demise was not kryptonite, and I'm speaking of Christopher Reeves. It was not the spinal cord injury that actually was his great demise. It was actually a pressure ulcer. So, and then pressure ulcers with our spinal cord injuries is a whole another separate issue, because you've got more than pressure going on there. You've got actually a change in how those nerves and tissue and all those structures that we now know about the skin, you've got a whole change of how they react because of the neurological damage. So this was one. This is another example that, what would you say, definitely is a incontinence-associated dermatitis, diaper rash, if you want to call it that. Maybe, maybe not. There could be some lesions out there, but this just at face value looks like it's somewhere. It's not pressure ulcer, we know. And that's one of the main points I want you to understand. We know it's not pressure ulcer. If we could see it in person, we might could tell a little different, but this is IAD most likely.
And you accompany this with them sitting or lying in that position for a long period of time with all that moisture.
And the fact that they are incontinent and whatever. So, and it doesn't take long to burn the skin. These, I throw these in a lot because I want you guys to know the difference. What are they? And those of you who have been in my lectures before, you know that this is the Kennedy terminal ulcer that Dr. Kennedy coined. You can look her up if you want to on Google her and see a little bit more about her studies and how she coined this and gave a name to this type of wound. These are end-life wounds that you might see on a patient that is actually, you'd think, well, this has got to be pressure and this has got to be related to these other things we've talked about. And in actuality, it's really part of the dying process, and which is almost a phenomenon that these wounds, obviously two different patients, almost mirrored in their presentation, and these patients expire and will expire within a matter of hours, 48, 72, no more than a week usually, typically. So I have had a few of you in past lectures and let me know that, yes, I have seen this, and then the patient died within a week or so. So if you see this come up suddenly and you can't quite determine why, it's most likely that there's something going on with this patient and that they're terminal.
And what was this called? Kennedy?
It's called the Kennedy terminal ulcer. Karen Kennedy Evans is the person who, the nurse who, Dr. Evans, I think she is, who coined these. She worked and did some research in a long-term care facility of about 700 patients and began to notice that these type ulcers would show up, these lesions, and then the patients would die pretty quickly.
Wow.
So that's just to help you differentiate. All right, so what are we going to do about all this skin breakdown? Well, we talked a little bit. We're going to treat the incontinence, which we didn't go into all those aspects today, but we've got to treat the underlying cause. We're going to check the skin daily, and then we're going to promptly clean the skin. And we're going to reinforce that with our home attendants, home health aides, which by the way, the home health aides, our ADPH home health aides, have had a modified version of this lecture, so they got a lot of this same information, so it can be reinforced. And also we're going to hopefully impart that to our patients and their caregivers of how important it is that they not sit in urine or feces, stay on the skin. Of course, with incontinence, you got to assess them, determine what kind of incontinence, what is the root cause, and then use some effective management. We touched on that a little bit about the constipation, the assessment. Again, if there's a patient out there, a case within the ADPH, and you want to be a little more aggressive with them, then get in touch with me and I'll be glad to help you if you don't have a local resource for continence care and assessment. And, you're going to gently wipe the skin when you're cleaning it. I think we've got that message out, hopefully. This is very important to let our home health aides or home attendants know that they are not to scrub the bottom. And actually some of the topical medication that we might use with the zinc, we don't want it scrubbed off, depending on what it is, that Baza cream and some of the other brands. And once once you get it on the skin, you'll want to use a perineal cleanser or a wound cleanser and to really get it off, but you never want to scrub because, you can see that skin's going to be compromised and you can really create a very difficult wound to manage. We want to use products that have a more acidic nature, pH closer to what the skin is, which is around 5.5. And then we want to protect them with a moisture barrier. That's very important. It'd be really nice if we could encourage our patients, maybe even work with your local administration and see about getting some sample sizes or something so that you can share with the patients. But that'll be something at the local level that perhaps you can do. You want to limit, we talked about the chucks and the linens and the diapers or blue pads or whatever you call those things, whatever you call them in your area. You really don't want to keep those things closed and tight on the patient. You don't want more than 2 layers. You don't want to just pile that on because, again, it will keep a lot of moisture next to the skin. try to find what can wick that moisture away so the patient stays dry. Don't use the pad as a diaper, and don't put the pad under the linen. Check the skin daily. We can't say that enough on a patient who we know is at high risk. Observe it. Take special notes, especially if they're in a chair, and they're incontinent. And again, this was to let the home health aides or home attendants know to report it, but also the nurses, that you report it to your supervisor if you need to discuss anything with them about what you can come up with. Don't rub or scrub. Clean it immediately and make sure that they're getting in those using something that's disposable is really better. Those peri wipes or peri spray, mild soap and water, and that they're drying the areas really well. Rinse it and dry it. Don't rub. Frequent baths, of course, is going to cause that natural oil is going to decrease with age and other comorbidities, but frequent bathing. So you want to look at how often somebody's bathing, if they're having some issues and rash and that kind of thing. Any off balance to that pH and to that mantle of the skin can create rashes and things. You can see that you get some damage that can occur. I actually had a patient one time who she was a young woman, but she never ever put soap on her body anywhere. She would she was in the bed, so I had to give her a bed bath, but she always used just like oil, like some kind of bath oil in that bath water, and I rinsed her with that. She had the most beautiful skin I ever saw.
Wow.
I know that's not feasible for all our patients. Sometimes they need a scrubbing, but we don't want to rub those areas that are tender. But if we can find something that will, moisture barrier or lotion that would be appropriate and not caked on in those skin folds, then that's a good thing.
Okay, now Jackie, let's go back. You said, that as we get older and bathing, has a tendency to dry us out, the more frequent. What about those patients that it's just a chore to give them a bath once a week?
Yeah. Well, with those, I recommend a bird bath, as we used to call it. Folks have different little names for it, but that's where you wash, in the very, you don't wash the entire body. They're not getting in the showers usually, and they're not getting in the bathtub. But, you're washing in those areas that are more likely to have the bacteria, which is under the arms, under the skin folds, under the breast, in the peri area. So you're concentrating on cleaning those areas. And then, maybe not applying soap to all of that. You might under the arms, but you might not in the peri area if it's, going to be a little more tender or irritated there. It might be best to use a peri spray on most patients. Okay. Clean it only when it's soiled. In other words, that if their skin is already compromised, that goes back to what we were just saying. Make sure that you're not using hot water. It should only be warm, and then the minimal force, no scrubbing. Now, here we go with dial. I know doctors recommend it a lot. We see it all the time where they tell us to wash with dial. But the dial soap is not the most appropriate pH for our patients, for any of us. So it's really hard to find a good right pH of soap. So maybe that patient I was telling you about really had something there where she was just using the bath oil. But if you've got a patient that already has some skin problems, I definitely recommend that they use that peri wash, something that has a more acidic and more balanced pH. It's not easy to find, but dial soap is actually not good. It is good if you're getting ready for surgery or something like that. And often the doctors will now will have you wash with an antibacterial soap from head to toe, even though they're having, surgery on their belly or whatever. But that helps to reduce of course, the bacteria load and keep them less likely to have infection after surgery. So they're, going to be breaking the skin because they have to. That's different. So really, if you've got somebody that's having a lot of issues, you might want to look at the kind of soap that they're wanting to use and what you have available. So it's optimal and these are just examples that I could get pictures of, to use something that's not too high in pH and that is more on the level of that 5.5 or a little bit lower. And the companies make all these. This is an antimicrobial cleansers. This is some hydrating cleansers. This is a peri-wash with no rinse. Baby wipes, they're not always the best either. You would think their pH would be perfect, but it might be better than using, the dial soap. So just keep that in mind. And I know you may not have these things available directly for your patients, but I would encourage you to, as you're staffing about a particular patient, it may be that you want to utilize something like this if you've got a really high-risk patient in order to prevent something. Maybe you get a sample, like I said, from one of our vendors, and then have the family purchase that if you feel like that's.
Now, are these by prescription only?
No, these things are all over the counter.
Oh,
but this first photograph that I'm showing you here are from Medline, and that's Medline's brand. And I think the one in the middle, it may be Sween, which can be purchased. That's the Sage, I think, not Sween. Can be purchased from Medline or other distributors.
But there's products just out there in our regular department stores.
Yes, you should be able to get something. You can ask the drugstore. They can order it for you. What has happened these days is I've found that, your local drugstores used to would get you anything. Well, now they're not as quick to do that because, I think it's costing them more money to keep it on their shelf, and, they're limiting their inventory. But most of these products they can get if they're whatever distributor they're dealing with, they can get a comparable product. These are, again, just samples that I could get photographs to show you guys.
And of course, remember, home health nurses out there, you got to get an order for all of this stuff.
Yes, in home health, you're going to have to get an order. You can make recommendations, and if the patients want to try it or whatever, then that's totally up to them. But if we are applying it and we are bringing it in the home, you have to have an order. Okay, so even if you're applying it and using it when you make the visit, then you've got to have an order, even though the patient's family has bought it.
And even if they have it in the home, we have to make sure that the doctor is. Oh, I'm sorry.
Yeah, that's what I mean.
Didn't catch that one, Jackie.
Yeah, if they purchased it and they have it in the home and you didn't bring it in there, you still have to have the doctor's order. If we do it, if you do it, you're an RN or LPN, you have to have an order for it. Okay. Now, protecting the skin. Well, the best thing to do is keep it moist. Moisturized skin is healthy skin. It'll prevent lots of problems: dryness, itching, again, the bacteria. You want to put it on damp skin. You want to let it lock in the moisture, apply it daily, but you don't want it caked up. You do need to be careful in the skin folds. You do need to be cautious with patients that's prone to the fungal issues. Maybe that they need an antifungal cream, or they need a prophylactic powder. They do make a lot of powders now, the antifungals, that once, you could use prophylactically if the patient wanted to use it, or if the doctor would give you an order. And those can be, you can get those over the counter as well.
Okay, so Jackie, you said to apply these to moist skin or damp skin. Okay.
Emollients soften and smooth, but they can add too much moisture. You have to be careful with those. It's good to have the skin exposed to air. And then, of course, if you want to, if they need something to step it up, the petroleum or petrolatum, which is petroleum, or the zinc oxide, or the dimethicone. These all also are moisture barriers, so that the urine and the feces can't affect the skin, so it protects them. That's the stuff that doesn't wash off easy. So these are just different types. There are all kinds out there on the market, over the counter. Boudreaux's butt paste, that's the one. I think we've got just, again, this is Medline's line of different creams. We've got protective wipes. That would be like for your skin preps and your peri areas to peri wound areas. Always, this is in our policies. We should be using skin prep with all of our dressings, so that you're coating the peri wound area with this protective coating. McKesson makes, I think theirs is called Moisture Skin Lotion. I mean, they're just generic in name, and it comes, obviously, you can see in these various sizes. Protected and treatment. I mean, again, we mentioned there's products that contain the zinc, balsam of Peru, that antifungal. There's a whole gambit of different products out there available. This again is just Medline's. There's a couple of others. One of these, I think, is just a closer look at the skin protective paste. That's that with the orange. And obviously I got the orange and the blue out there. How about that? HydroGuard, which is the got the silicone blend to it. So there's even the silicone products out there on the market. Elta, you don't see it on the shelves. You might ask the local pharmacy if they can get it for you. It's made out of Europe, and it is really, really nice. We always used to love to get those samples when we would go to the meetings. They don't pass things out like that much anymore, but it's a really great moisture barrier. It's got really good skin lotion line. You just want to look for something that is, I mean, even these are common. Boudreaux's butt paste, which actually was manufactured at one time, I don't know if it still is, out of South Alabama, but Mr. Boudreaux out of Louisiana, who developed this, is from Louisiana. And so first time I heard it, I was already a WSCN, and I was like, the what? The what butt paste? I didn't know it was a real thing, but it is. And then, of course, A&D ointment. You've got Vaseline with the petrolatum. What I hope that you take away from this, and me just giving you a few examples, is that there's a whole lot of things out there. There's an antifungal powder that is with Medline, which is really, really good. Other people make it. You can even get, like I said, over the counter. There's an antifungal that is clear. It doesn't have, it's an ointment. It's not a moisture barrier. If you need antifungal and moisture barrier, there's plenty of those out there. That one in the middle is Coloplast brand, which is called Moisture Barrier Antifungal Cream. So what I hope you get is that out of this is that there are a number of products on the market, but you need to know what you need on there. Do I need an antifungal? I hope you have a better idea about that. If I need an antifungal, do I need a moisture barrier? Well, if I've got a lot of moisture, if I've got a lot of urine, if I've got feces, liquid feces that is going to be on the skin, then yes, I'm going to want something with a moisture barrier, not just lotion. If I've got a pretty relatively healthy person, as far as their skin, I might want to go ahead and just use a good moisturizer because they're older, their skin's getting thin, it's loose, and that's going to keep the skin lubricated well, so that these things are prevented.
Now, Jackie, when are you going to use that antifungal?
Antifungal, you're going to use that if you have someone who is prone to the yeast infections like we saw, so they may use it preventatively. They may use it to actually treat a mild case. And it may be good enough rather than going to the prescriptive product.
Oh, okay.
So there's a number of those out on the market that are over the counter. Again, you may not see this particular brand at your pharmacy because these are brands that are usually marketed and secured through facilities like hospitals, nursing homes, and home health agencies.
Okay. Well, that's been a lot of good information, and it sure has refreshed my memory and gives me a better perspective on if I am back out in the field and what I'm going to look for, and wound pictures that I'm going to look at, or skin pictures that I'm going to look at, from our ADPH employees when they assess their patients. So, well, Jackie, you have anything more you want to tell us before we close this evening?
Well, I do say we have a little time. If you guys have questions, please send those in right now. It'll be a good time for us to discuss them. I talked a bit about incontinence. You can please let us know what you would like a class on if you want to go into more depth with the causes and the types of incontinence. We've done a number of things on pressure ulcers, so you might not really want that, but you can let us know. Another concern that we have is managing our leg ulcers, and so I can certainly do something on that, or we can arrange to have a speaker. Sometimes we're able to get national level speakers, and you don't have to listen to your own expert. But with the incontinence, I think it is, again, it's a problem that we're going to continue to see. There's a few other little terms that they're throwing around out there related to incontinence, but I think you'll see IAD as a pretty well accepted term now across the board in clinical settings as incontinence-associated dermatitis. Again, what the purpose of this was to help introduce you to that and also distinguish between that and pressure ulcers. It's very, very, very important that we get our assessments correct with our patients on the OASIS. Of course, y'all know that affects our reimbursement in hospitals and in nursing homes. That it very much affects their reimbursement because if the pressure ulcer has developed on their watch, then they're not going to be paid, and I'm sure those things will definitely trickle down to home health at some point. And so you want to be sure that we've assessed it appropriately, not just if you see a red area on the buttocks that, okay, it's a pressure ulcer. It may not be yet. You saw the combination of IED and pressure, so we could have both, but we just want to be real cautious about labeling something until we're pretty certain what it is. And what I really would like to do is empower you, now that you've heard this lecture and you can think back on some of it, that you are empowered to share this information with your clinicians, your physicians, your nurse practitioners, the people that you're interacting with related to this kind of issues with your patients. Because now you're the expert. I think we have a question.
Yes. The question is, how much care can family members provide in terms of the care required for dermatitis treatment?
This is not a skilled issue. The skill service in this is being able to recognize and assess appropriately what the problem is. That's your skill. And observing whether it's getting worse, whether it's getting better, whether it's developing into yeast, whether it's developing into a pressure ulcer, and that sort of thing, or if there's something else going on altogether. The cleaning of a bottom and applying most of these things we've talked about is not a skilled service. It's not. It would be a non-skilled service. So it'll be something that you can teach your family members. That's a good question.
You know, as far as a a family member or caregiver writing in this, one of the most important things I see is making sure that you know what it is. Don't just go out there and buy something, because what you may purchase from what you think it is may not be what it is, and it can do more harm than good.
That's
so
right.
if you don't have a home health or anyone coming into the home, make sure that the patient sees the physician so they can diagnose the condition appropriately and prescribe the right medication for this.
And then in home care, we're the eyes, we're the ones that are looking at the patient for the physician and reporting back to him what we think. The next step of that is if you think it's one thing and you use a product for 3 weeks and you see no difference or it gets worse, then obviously we hadn't hit on exactly what's causing the problem. So that we might need to back up and look at it again, reassess it, counsel with the doctor. Again, we've seen some examples that in our patient population where things can get out of hand really quick in the peri area and in these wounds, and then discover that we're actually dealing with something much more serious and much less common. So if it doesn't look like a duck, doesn't quack like a duck, and it doesn't have feathers like a duck, after a while we got to decide this might not be one. So it's rather surprising at some of the unique patient situations that we have just within our patient population.
Along that line, Jackie, from being in the field of home health care and working with nurses that aren't as experienced as some, would you focus more on telling them how to remove the source of the incontinence? Because I have gone into homes where a patient has had the dermatitis happening and the wounds weren't healing, and it was because the nurse didn't realize she needed to remove the source of the incontinence by maybe talking with the doctor about possible temporary catheter placement, especially for females.
That's a really good point. Yes, the push is away from catheters. We don't have many indwelling catheters anymore. Indwelling catheter is really a last resort to deal with incontinence, and it's only appropriate in very certain cases. And it's certainly not appropriate in most cases long term. We know that now. We know that it can cause more problems than it should. But, as you said, yes, it can be appropriate. That's part of your nursing judgment and your assessment skills that you're going to report back to the physician, and maybe, off the cuff he's going to say, oh no, we can't do that. But when you describe the wound and what you think, and can we try this for about 3 weeks along with the whatever topical that you're using, and if it's a bowel incontinence and they've got loose bowel because they've had some problems maybe with their G-tube management and they're changing formulas or whatever, then it could be a temporary thing. So that would be appropriate, and that would be an appropriate thing to recommend to the physician.
And Jackie, I look at this as off of what Mary said there, it's like any other disease process. If you have a patient with CHF and they keep having an exacerbation of CHF, you're going to look to see why. Why are they having an exacerbation? Are they not following the diet? Are they taking their medicine and whatever? And it's just the same thing I look at as incontinence. What is causing this skin to break down over and over and over again? Because you can teach them good skin care, but if they're not doing it,
right.
You're just totally defeating the purpose.
Right.
So
We're not getting to the core issue, and again, I encourage you not to look at someone just because of their age. Oh, they're going to be incontinent no matter what. Again, maybe they're constipated, and we can take care of that. And as you know, that the liquid stool with someone who's impacted can come around, and they can say, "Oh, we're having diarrhea," when in fact they are impacted. So, that's basic nursing, but, I don't hear about anybody digging out impactions much anymore, but people still have them.
exactly.
People still have them. There may be a way to get it, some suppositories, some fleets, some other things, but, think in terms of the basics and rule out everything as you do your assessment.
We have another question. How do you determine if the lesion is due to IED or pressure?
Okay. Well, I hope that you picked up some clues on that. Just to reiterate what we talked about, first of all, the location. Where is it? Is it over a bony prominence? If it's over a bony prominence, could be more related to the pressure. This is just looking at the wound. Is it more of a scalded bottom? Is it more of a diverse, spread out area, or is it very concentrated? Are the edges pretty much defined? Are they not defined? If they're not defined, it's probably urine associated, or feces. If it is defined, it may be the pressure. And then go back to just assessing the whole patient. What's going on with them? Are they incontinent? How many times a day are they incontinent? Are they sitting on 10 pads? Are they, what else is going on with the patient? What is their diet? Are they eating some things that we mentioned in this? We didn't go into depth, but are they eating some things that is causing their urine to not be at the optimal pH, so that they're going to increase their chances of having skin breakdown based on the pH of the urine? So start with the basics and kind of go from there is what I would recommend that you do on your assessment.
Okay, Jackie, let's touch on nutrition just a few minutes here, because I think you touched on it in your slides there, but let's elaborate a little bit about nutrition and how, and skin care.
Mm-hmm. Well, of course, nutrition is basic to our health, whatever the issue is. If you're not getting in appropriate nutrition, or you have a disease process that is causing you not to be able to metabolize and utilize the appropriate nutrition, then you're not going to be healthy. I mean, it is a basic pillar of health. I always encourage our staff. I don't think this is done very often. There is a nutritionist somewhere in your county health department. I would make them my best friend, not just because I like food, but because I have always found in my practice, in every setting I've ever been in, that the nutritionist and the social worker were the two people that I wanted to make sure I had a relationship with and utilize their expertise. I realize that they're in WIC or whatever, and they're not there to service our home health patients, but they would be my best friend. And quite often when we've had one here at the Bureau, they were my best friend because I would go and ask certain things. So I would encourage you to utilize resources that are there available to you, I know, in our local county health departments, to just pick their brain, maybe get some ideas. If you're having a concern because this patient is, well, I'll give you an example today. Probably our patients aren't going to do this, but I don't know if you've noticed the phenomenon of the cuties, the halos, the little clementine oranges. Mm-hmm. Well, even me and my daughter, she loves them. She will eat 6 of them a day, or maybe more. And we would never peel an orange. I don't know why we wouldn't do a whole orange, but those are just the perfect little serving size. Well, I think they're great. All our patients need them. But if you're eating 10 a day, you're going to make that urine a little too acidic. It's good to be a little bit acidic, but not too acidic. So obviously that would be something. So again, assessing the patient's overall well-being, their diet, their environment. So many factors can play into this. Nutrition, y'all have been out in the homes. I know what it's like when I go to the grocery store. I can only imagine the issues that you're dealing with today, and making, doing what you can to make sure that your patients have food in the home, as well as appropriate diet, because they're going to eat that red. Some of those patients are going to eat that sausage with the big thick red covering and all that, no matter what we tell them, right? So you're going to teach them about all the nutritional facts, but what I've done in my practice now is when I encounter patients in some other settings, one-on-one, I encourage them to try one thing. So if it's add the cutie, if it's add some fruit or vegetable to the diet every day, that's inexpensive if they can. And that. I mean, we know what would be optimal, but start with just a basic one little change that you can help them make.
We have another question. Is it acceptable to use a smartphone to take a picture so that it can be shown or transmitted to the physician for diagnosis?
In our agency, in the Alabama Department of Public Health, it is absolutely not okay. You can check with your agency. I have heard that there are some that have been using their smartphones, but wherever you are, you need to be certain that you've checked with your agency and what they're recommending. The HIPAA laws are very strict and very clear. The way we've interpreted them isn't always clear, but we are now seeing litigation in that arena. We'll probably see more. We see people that are very concerned about their private parts being shown, even though there is absolutely no way that they could be identified. I've had physicians I know that have told our staff, take a picture and send it to me. But in our agency, I want to be very clear, in Alabama Department of Public Health, you cannot take a photograph with your telephone. I know in some other companies, other settings, it has been immediate dismissal in other settings if nurses have had their phones. Nurses have actually used the Facebook to discuss patients, and that too is totally inappropriate, and it cannot be done. Even your best bet is to not do it at all. Don't go there, even if you think that you've protected their confidentiality. It would be very, very easy to get into big trouble in any agency. But in our agency, it is absolutely forbidden.
And you know, we at Alabama Department of Public Health, we do furnish our nurses the tools and the resources to take those photos.
Yes.
And we know that it is all legally done.
Yes.
That way. One other thing I wanted to touch on before we close here, and Jackie, you had said something about making that nutritionist and social worker your best friend. And you are absolutely correct. The social worker is my very, very, very best friend, because for all of those products that would be great on that patient, and for the Depends or the diapers or whatever they are going to use, the social worker has all of those great resources that, and I as a nurse, I just say you just need to go buy them, but I know that that social worker has all the great resources that they can help that patient and family purchase what they need to take care of the problems that they have. So I just really want to enforce what you said of yes, you know, that social worker is just one of my very best friends.
Yes. And if you, and we do have that system where you take photographs and it goes into our clinical documentation securely, and I can see those and access those. So when I'm consulted on a complicated case, I always say, have you made a social worker referral? That's gonna be my first question. And then probably the second, because I know we have social workers available out there. My next question may be related to the nutrition. Even though we don't have a nutritionist for home care, we have to find those resources.
And we do have access to them.
Yeah.
Yes. Well, are there any more questions? Yeah. Jackie, is there anything else that you want to say before we close?
No, thank you, and thank you so much for listening and for your questions and the interaction that we've had today.
Well, you have brought us a lot of valuable information, and I know that I am more knowledgeable by being here and listening to you. So thank you so very much. And please remember, if you have any emails, you can always send them to the email address, and they will get back to Jackie so she can respond appropriately. So thank you very much for joining us today, and just have a blessed day.